Bismillah ar-Rahman ar-Rahim. Our lecture today will be about the causes of short stature, and the most important endocrinological cause for the short stature is hypopituitarism. The objective of this lecture is to know the definition of hypopituitarism, what are the causes of this disease, what are the clinical features, whether it is congenital or acquired, how to reach the diagnosis, and what is the treatment and the adverse effect of the treatment. Hypopituitarism, it means underproduction of growth hormone, alone or in combination with deficiency of other pituitary hormone, thus to say anterior pituitary hormones. Affected children have postnatal growth impairment that is specifically corrected by replacement of growth hormone. The incidence of hypopituitarism is between 1 in 4,000 to 1 in 10,000 live births. The etiology: either we have multiple pituitary hormone deficiency or isolated growth hormone deficiency. Regarding multiple pituitary hormone, there are many genetic forms, that is inherited forms of pituitary hormone deficiency, and others acquired form, and the most common lesion is the craniopharyngioma. In addition to that, there is CNS germinoma, eosinophilic granuloma, that's to say histiocytosis, TB of the brain, sarcoidosis, toxoplasmosis, meningitis could be complicated by deficiency of the pituitary hormone, and aneurysm may also cause hypothalamic hypophyseal destruction. In addition to these acquired causes, there is a trauma, which including shaking child syndrome, in which the mother shaking the baby when she became angry with him, motor vehicle crash, traction at delivery, anoxia, and hemorrhagic infarction may also cause damage of the pituitary or its stalk or the hypothalamus. Isolated growth hormone deficiency and insensitivity. In addition, also there is a genetic form of growth hormone deficiency, that is inherited forms, and also there is acquired form, and the most important is the use of radiotherapy for the malignancy. Previously we used radiotherapy for the treatment of patients with leukemia when there is CNS involvement. So when they use radiotherapy for malignancy, in addition to that, meningitis, histiocytosis, and trauma. So these causes may cause either isolated growth hormone deficiency, or they may cause multiple pituitary hormone deficiency. There is an entity which is called growth hormone insensitivity, in which there is abnormality of the growth hormone receptors, or there is post-receptor form of growth hormone insensitivity. In these cases, the secretion of growth hormone is normal, but there is no response to the growth hormone, and the patient presents with features of growth hormone deficiency. Regarding the clinical manifestations, we will start with congenital hypopituitarism, in which the child is usually of normal size and weight at birth. This is very important. As patient with small for gestational age, it is not regarded growth hormone deficiency as a cause. So it is normal, he is normal size and weight at birth. With the time, patients with severe defect on growth hormone production or action are more than 4 standard deviation below the mean by 1 year of age. So there is deceleration of the growth during the first year of age. Infant may present with neonatal emergencies such as apnea, cyanosis, or severe hypoglycemia, with or without seizures. So growth hormone deficiency, it enters in the differential diagnosis or the causes of neonatal hypoglycemia. Another clue for the diagnosis, especially in boys, is the microphallus, which will provide an additional diagnostic clue. A prolonged neonatal jaundice is also common, and it can occur as we will see in congenital hypothyroidism may be regarded as one of the cause of prolonged neonatal jaundice. In addition to that, there are special phases for the patient with congenital pituitary or growth hormone deficiency. The head of the toddler is usually round, and the face is short. The nose is small, and nasolabial fold are well developed. The eyes are somewhat bulging. The neck is short and the larynx is small. The voice is high-pitched and remains after puberty. So the voice of the baby will remain and not affected by the puberty. The extremities are well proportioned with small hand and feet. So the proportional between the upper and lower segment is well maintained in patients with growth hormone deficiency. This is in controversy with congenital hypothyroidism, in which the short stature is disproportional. So the child with growth hormone deficiency is a normal child but in a small size. The weight for height is usually normal and maintained, and sometimes the weight may be more. The genitalia are usually small for age, and sexual maturation may be delayed or absent, especially if the patient had additional FSH and LH or gonadotropin deficiencies. Facial, axillary, and pubic hair is usually lacking, and the scalp hair is fine. Symptomatic hypoglycemia, usually after fasting, occur in 10 to 15% of children with hypopituitarism and those with isolated growth hormone deficiency. So it's enter in the diagnosis of children with hypoglycemia, not only neonatal hypoglycemia. Intelligence is usually normal, not affected, and this differentiates it from congenital hypothyroidism, in which the patient presents with short stature, but there is mental retardation. This is the pictures of show the part of the clinical features which may be seen in patient with congenital with isolated growth hormone deficiency or with multiple. So you will see the difference in the height, but it is well proportionate and well proportionate. Look like this, but this is in a small size. Okay. In cases of acquired hypopituitarism, that's to say when the patient develops growth hormone deficiency because of trauma, because of meningitis, because of craniopharyngioma, the child is initially is normal. Manifestations similar to those seen in idiopathic pituitary growth hormone or growth failure gradually appear and progress. When complete or almost complete destruction of the pituitary glands occurs, signs of pituitary insufficiency are present, so the features will develop gradually. In patients with atrophy of the adrenal cortex, thyroid, and gonads result in loss of weight, asthenia, sensitivity of cold, and absence of sweating. This is to say when there is hypopituitarism. Sexual maturation will fail to take place or regress if already present. There is tendency to hypoglycemia. Growth slow dramatically. First, the growth is normal, but later on it will be slow dramatically. In acquired growth hormone deficiency, if the lesion is expanding a tumor, symptoms such as headache, vomiting, visual disturbances, pathological sleep pattern, decreased school performance, seizures, polyuria, and growth failure may occur. Sometimes slowing of the growth may antedate neurological signs and symptoms, especially with craniopharyngioma, but symptoms of hormonal deficit account only for 10% of presenting complaint. So the patient may have regression of the growth and he does not catch up growth because of the lesion, but the family does not notice this is as a symptoms to present with. It constitutes only 10% of presenting complaint, while 90% of them they present with neurological signs and symptoms. Evidence of pituitary insufficiency may first appear after surgical intervention, so always they are referred from a neurosurgery department to us. In children with craniopharyngioma, visual field defect, optic atrophy, papilledema, and cranial nerves are common. So one of the important investigations we did for the patient with growth hormone deficiency is to do MRI of the brain to exclude secondary causes of growth hormone deficiency. Regarding the laboratory findings, the diagnosis of growth hormone deficiency is suspected in children with moderate to severe postnatal growth failure. The criteria for the growth failure include height below first centile for age and the sex, or height more than 2 standard deviation below mid-parental height. What we mean by mid-parental height, that we will take the height of the father and the mother, and there is a special equation to calculate the mid-parental height. And then, if the patient, at the height of the patient, more than 2 standard deviation below the mid-parental height, we regard him, this is a candidate to be investigated for growth hormone deficiency. Acquired growth hormone deficiency can occur at any age. When it is of acute onset, height may be within the normal range, but growth velocity decline. This is what we mean by this is that sometimes in acquired causes of growth hormone deficiency, we find the patient is on the 10th centile or 25th centile. But when we go to his growth previously, he was on the 50th centile, and then the growth velocity decline and become on the 25th centile, and if we leave the patient, then he will go into below 3rd centile or below the 1st centile. We cannot wait until the growth velocity decline more and more. We must do the investigations immediately. A strong clinical suspicion is important in establishing the diagnosis because laboratory measures of growth hormone deficiency lack specificity. All the laboratory measures, they are not 100% specific for the growth hormone deficiency, so clinical suspicion should be maintained. A definitive diagnosis of growth hormone deficiency traditionally requires demonstration of absent or low level of growth hormone in response to stimulation. So we don't depend on basal growth hormone. We must do a stimulation test. A variety of provocative tests has been devised that rapidly increases the level of growth hormone in normal children. These include administration of insulin, arginine, clonidine, or glucagon. In all these cases, we either induced hypotension or we induced hypoglycemia in order to stimulate growth hormone deficiency. In Iraq, the usual provocative test we use is clonidine to induce hypotension and glucagon to induce hypoglycemia. That's to say, glucagon for the first time it caused hyperglycemia, but later on it caused rebound hypoglycemia. So we take the sample when the patient developed hypoglycemia during the phase of rebound. Doing this investigation in chronic growth hormone deficiency, the demonstration of poor linear growth, delayed skeletal age, that's the bone age, and peak levels of growth hormone less than 10 nanogram per ml in each of two provocative tests are compatible with the growth hormone deficiency. So, demonstration of the deceleration of growth velocity with delayed bone age in addition to the lab investigations. In acute growth hormone deficiency, a high clinical suspicion of growth hormone and low peak levels of growth hormone in each of two provocative tests are compatible with the growth hormone deficiency. We don't need here delayed bone age because it is of acute onset. A majority of normal prepubertal children fail to achieve growth hormone value more than 10 nanogram per ml with two pharmacological tests. So, we use what is called as a priming. 3 days of estrogen priming may be needed prior to growth hormone testing to achieve greater diagnostic specificity. This can be used both in male and female. In addition to establishing the diagnosis of growth hormone deficiency, it is necessary to examine other pituitary function. When we reach the diagnosis of growth hormone, we must be sure about the level of the TSH, T4, ACTH, cortisol, gonadotropin, and gonadal steroid, which may provide evidence of other pituitary hormone deficiency, because if there is deficiency of these hormones, we must treat these and replace these hormones, especially the cortisol and thyroxine, before we give growth hormone for the patient. The defect can be localized to hypothalamus if there is a normal response to administration of hypothalamic releasing hormone for TSH, ACTH, and gonadotropins, but rarely we use this in our hospitals. Regarding the radiological finding, skeletal maturation, that's to say, bone age, is delayed in patients with isolated growth hormone and may be even more delayed when there is combined growth hormone and TSH deficiency when there is panhypopituitarism. The bone age, we measure it by using a special atlas for the calculation of the bone age. There are two methods. One method, what is called as RAS, radio-ulnar small bone scoring, which is British, and what is called other way is Krulich and Bile, which is Almania. In both methods, we calculate the estimated bone age. Bone age, sometimes it is compatible with the chronological and sometimes it is delayed according to the cause. So in growth hormone deficiency, there is delayed bone age, which is one of the pillars for the diagnosis of growth hormone deficiency. In addition to this, we need CT scan, which is appropriate for recognizing supracellular calcification associated with craniopharyngioma and bony erosion accompanying histiocytosis. MRI may provide a much more detailed view of hypothalamic and pituitary anatomy, especially when used with contrast. Regarding the differential diagnosis, there are many causes of growth disorders. Growth hormone deficiency is not the common cause for the short stature in the community. The commonest cause for the short stature in the community is are genetic short stature, in which one or both parents are short. And when we calculate the midparental height, the height of the baby will be within the midparental height. In addition, there is a normal bone age. There is no delay in the bone age. Another common cause for short stature is a systemic condition which must be excluded by history, by physical examination, by investigation before we go for the investigation for growth hormone deficiency, such as inflammatory bowel disease, celiac disease, which is mandatory to be done before growth hormone stimulation test, occult renal disease, anemia may be considered. Patients with systemic condition often have greater loss of weight than length. This may give a clue to the possibility of systemic condition. There is what is called idiopathic short stature, in which a few otherwise normal children are short, more than 3 standard deviation below the mean of age, and grow 5 cm per year or less, but have normal levels of growth hormone in response to provocative tests and normal spontaneous episodic secretion. So these patients, they are short, they have deceleration of growth velocity, but they have normal levels of growth hormone. Most of these children show increased rate of growth when treated with growth hormone in doses comparable to those used to treat children with hypopituitarism. We give growth hormone as a trial, they are responding and they have good response. So they may get benefit from growth hormone deficiency, although they are not growth hormone deficient. A plasma level of insulin growth factor 1 in these patients may be normal or low. This is an indication for growth hormone in United States of America, while in European it is not an indication for growth hormone treatment. The fourth differential diagnosis, it was called constitutional growth delay, which is a common variant of normal growth. Always we see our grandma or grandfather, they said, you are, or some of the sons or daughters, they are short, and then they catch up growth during puberty. Length and weight measurement of affected children are normal at birth, and growth is normal for the first 4 to 12 months of life, not like growth hormone, as we said, there is deceleration of growth during the first year of life. Height is sustained at a lower percentile during childhood, so he got his height, but it is a lower percentile. The pubertal growth spurt is delayed, so their growth rate continued to decline after their friends had begun to accelerate. As we remember, and we will take when we discuss the growth charts, there is a growth spurt, which is concomitant or occur at the same time with the puberty. In these patients, the puberty is delayed, so the growth rates remain on the pre-pubertal level. The other patient or the other person who got his puberty will has catch-up growth, and while our patient will still short in his height. Detailed history often reveals other family members, frequently one or both parents, with histories of short stature in childhood, delayed puberty, and eventual normal stature. IGF-1 levels tend to be low for chronological age, but within the normal for bone age. Always those patients, they have bone age which is delayed just 1 or 2 years from chronological age. Growth hormone response to provocative testing tend to be lower than in the children with more typical timing of puberty. But in these cases, we concentrate on priming, as we said, using the estrogen for 3 days before using growth or performing growth hormone stimulation test. These patients, they are not treated with the growth hormone at all. It is not an indication for growth hormone treatment. The prognosis for normal adult height in these children is good. Boys with more than 2 years of pubertal delay may benefit from short course of testosterone if they want as a treatment to hasten puberty for psychological cause, and especially if the patient delayed or still in short after 14 years of age. The cause of this variant of normal growth is thought to be persistent of relatively hypogonadotropic state of childhood. Primary hypothyroidism is the fifth differential diagnosis, which is more common than growth hormone deficiency, in which there is low T4, elevated TSH will establish the diagnosis. Response to the growth hormone provocative test may be subnormal because thyroid hormone is necessary. For the normal growth hormone synthesis, it must always be assessed before growth hormone evaluation. So, when we want to do a test for the growth hormone stimulation test, we send the patient for a general investigation to exclude systemic disease. In addition to that, we send specifically for celiac because it is common in our community, and we send for thyroid function test. If all of these are normal, then we go for growth hormone stimulation tests. The sixth differential diagnosis, it is what is called psychosocial dwarfism. Emotional deprivation is an important cause of retardation of growth and mimics hypopituitarism. The condition is known as psychosocial dwarfism, maternal deprivation dwarfism, in which there is functional hypopituitarism, which is indicated by low level of IGF-1 and by inadequate response of growth hormone to provocative stimuli. Puberty may be normal or even premature in its appearance. Appropriate history and careful observation reveal disturbed mother-child or family relation and provide a clue to the diagnosis. A proof may be difficult to establish because the parent often hides the true family situation from a professional, and the children rarely can talk. So the diagnosis is very important, or sometimes it is very difficult by history. Emotional deprived children frequently have abnormal or voracious appetite, enuresis, encopresis, insomnia, and crying spasm. So these features may give a clue to the diagnosis in addition to the premature puberty. Regarding the treatment, in children with classical growth hormone deficiency, treatment should be started as soon as possible to narrow the gap in height between patients and their peers during childhood and to have the greatest effect on mature height. So, the earliest we start the treatment, the better the response. But as we know, growth hormone treatment is not always available in our hospital because of logistical issue. The recommended dose of growth hormone is 0.18 to 0.3 milligram per kg per week, not per day, during childhood. Higher doses have been used during puberty. Recombinant growth hormone is administered subcutaneously for 6 or 7 divided dose, always for 7 divided dose. We don't have an off. Growth hormone should be continued until near final height is achieved. When the final height is achieved and there is closure of the epiphysis, we stop the growth hormone. Some patients develop either a primary or central hypothyroidism while under the treatment with growth hormone. And similarly, there is a risk of developing adrenal insufficiency if unrecognized. This can be fatal. So, periodic evaluation of thyroid and adrenal function is indicated for all patients treated with the growth hormone. We did the test before the diagnosis, but we must do periodic evaluation, especially when there is some symptoms may suggest this. In addition to the growth hormone, in the United States of America, they use what is called recombinant IGF-1. It is given subcutaneously twice a day. The risk of hypoglycemia is reduced by giving the injections concurrently with a meal or snacks. In certain situations, its use will be more effective than use of growth hormone, especially in cases of Laron syndrome, when there is deficiency of IGF-1. The defect in the IGF-1, the defect is not in the growth hormone secretion. Growth hormone is currently approved in the United States for treatment of children with growth failure as a result of, in addition to the growth hormone, it is approved for patients with Turner syndrome, end-stage renal failure before kidney transplant, that's to say with good metabolic control. In cases of Prader-Willi syndrome, intrauterine growth retardation when they don't catch up growth after 4 years of age, and in idiopathic short stature. In children with multiple or pituitary hormone deficiency, replacement should be always directed at other hormone deficiencies, not only the growth hormone. Adverse effect of growth hormone. Some patients treated with growth hormone have developed leukemia, but it is not proved that leukemia is because of growth hormone deficiency. So it is published that it does not increase the risk of recurrence of brain tumor or leukemia. And I saw patients that are cured from leukemia treated with growth hormone deficiency for their short stature. Other reported side effects include pseudotumor cerebri, slipped capital femoral epiphysis, gynecomastia, and worsening of scoliosis. So scoliosis is contraindication for the use of the growth hormone treatment. There is an increase in the total body water during the first 2 weeks of treatment, and some patients may have headache, and they have pseudotumor cerebri, and so the patient, when develop headache during the early phase of treatment, we send for the ophthalmology. If there is papilledema, we stop the treatment and return back with a smaller dose later on. Treatment does not increase the risk of type 1 diabetes, but it may increase the risk of type 2 diabetes. The treatment impair glucose tolerance test.